3, 2, 1. We are live now.
Good evening, friends. Greeting from Uttarakhand. It's our privilege today that we are organizing webinar with legends of Paediatric Orthopaedic Society of India. Myself, Dr. Puneet Agrawal, Secretary Uttarakhand Orthopedic Association. I will like to welcome all our faculty members and all delegates. Today, Dr. Chetan from Himalayan Institute, Jolly Grant, will moderate the session and he will take care of next. Dr. Chetan, over to you.
Thank you, sir. Today we have four faculty. The theme of the webinar has been kept as upper limb trauma in pediatric age group. So we have Dr. P.N Gupta from GMCH Chandigarh, Dr. Dhiren Ganjwala from Ahmedabad, Dr. Kapil Gangwal from Jaipur, and Dr. Nirmal from PGI Chandigarh, who will be with us in this webinar. So we will be starting with Dr. Kapil, who will talk about the first topic, the elbow injuries in children. So his topic is going to be lateral condyle fractures of humerus in children. What do you need to know? So Dr. Kapil, it's over to you.
Okay, I'll just share my screen real quick. Okay, I think am I audible, visible? Yes.
Yes, sir, you are audible.
Okay, so lateral condyle humerus fractures, as we know, are the second most common fractures around the elbow in children, secondary only to the supracondylar humerus fractures, and the peak age is around somewhere around 6 years. And the mechanism of injury is usually either a pull-off fracture, which is secondary to a varus strain, and the extensor attachments on the lateral condyle actually pull the fracture off. And it's also the most common mechanism of the injury that we see. The other is the push-off, which is a direct pressure on the lateral condyle from the radial head, and that's secondary to a valgus force at the elbow. And it's the less common kind of a fracture pattern. Numerous classifications have been described for this injury. Milch is the classical kind of classification that we've all read. It's based on the path of the fracture line. The type 1 goes through the capitular ossification center. It's more or less commonly encountered fracture pattern. The type 2 is through the ulnar trochlear groove, and these fractures are angulated and translated. This Milch classification, though it's most well known, but it's got low prognostic value regarding the treatment and complications of these fractures. The other classification, which was a kind of a subvariant of the Milch, was the Mirsky, in which he described that the fracture was actually exiting in about 20% of the cases that he reviewed through the medial condyle. And this is just a case example of that. And you can see that the fracture line goes through the medial condyle. It's actually a kind of a low supracondylar kind of fracture with a transphyseal extension. So the Jacob is the more well-known classification. In 1975. It was based on cadaveric experimental studies on the creation of fractures, and he based it on the presence or absence of a medial hinge, which was the key factor in the stability of the fracture. And it was a classification which correlates with the treatment as well as the prognosis. And he described 3 types. The type 1 is the minimally displaced. The type 2 is slightly displaced, but there's no rotation. And the type 3 is displaced and rotated. The more recent classification is that of Song in 2007, and he described 5 types. The type 1, 2, and 3 actually match with the Jacob 1 classification, and the stage 4 with the Jacob 2, and the stage 5 with the Jacob 3. And we look at these in a little more detail as we go along. So the most important thing is the fracture orientation is not in the frontal or the lateral plane. It's in an oblique plane. And it goes from the proximal portion from the posterior side and goes on the medial and anterior side distally towards the articular surface. And the grossly displaced ones are obvious and you can pick them up easily, but the minimally displaced ones are missed easily. And so we need to be really careful in picking up this injury. The really diagnostic kind of investigation is the internal oblique AP projection of the elbow. which really brings the fracture into profile. And that's actually an essential radiographic projection that we must order when we are dealing with lateral condyle humerus fractures, as it shows the displacement in the full form. So the minimally displaced fractures are the ones which are the most controversial, and we need to decide whether they are stable or they are unstable. So the stable ones are those in which the articular hinge is intact and the fracture ends proximal to the articular surface. And the unstable ones are which go across the articular surface, and these are prone to displacement. And the investigations really which show this in the acute stage is an arthrogram or a MRI, and both of these are difficult investigations to get in the child with these fractures. So looking at treatment, and we'll cover the displacement in a little bit. So then the Jacob type 1, the treatment is cast immobilization. It's usually for 4 to 6 weeks, and you follow up with X-rays at 1, 2, and sometimes at 4 and 6 weeks if you want to be very careful. But the ones which want to displace will displace usually in the first week to check for secondary displacement. So this is a child with a minimally displaced fracture and treated in cast. And you can see there's a little bit of fracture line visible on the internal oblique projection, but the cast was continued and went on to heal uneventfully. So the non-displaced or the minimally displaced fractures, we need to really be able to predict that which ones are the ones which are going to trouble us and which are going to go on for secondary displacement. And this is an interesting study by Finn Bogosen, and he described 3 fracture patterns. Then one in which the fracture line was divergent laterally, the one in which it was parallel, and one in which it was divergent on the medial side. And the ones in which it was divergent on the medial side of the fracture line was parallel were the ones which were likely to go on for displacement. So the secondary displacement, to check for that, we need to get an X-ray out of the cast in about 4 to 7 days. You need to look for the displacement. Medial displacement is more significant than lateral. And if displaced, you want to treat as unstable fracture. If undisplaced, you want to recast and repeat the X-ray after further 4 days. And if it's not displaced, it's treated closed. And if it's displaced, you need to pin it. Okay, I'm just going to stop share for a second. I think there's a problem with this presentation. Just give me 1 second. Okay, sorry for that. Just give me a second. Okay, so if it's displaced, then we need to go and pin it. So this is a child who had this fracture you can see on the left side. And about a week later, X-ray out of cast showed that the fracture had displaced. Went on for a close reduction pinning, and it went on to heal uneventfully. So the song classification, actually he gave an algorithm along with the classification, and it shows that the minimally displaced ones you just observe or you pin in situ, and the ones which displace, you need to go and close reduce and pin. He also described a method for close reduction for the more displaced fractures. I have no experience with that, but the more experienced surgeons who have experience with this technique can sometimes get away with a close reduction in the more displaced ones as well. So this is a child with a lateral condyle fracture that's about 1 week from injury, and these ones I typically go and close reduce, and I use a towel clip to reduce it. I put a kind of a felt on the medial aspect to protect the skin, and once you've got the fracture lined up, you check it on the internal oblique projection, pass a wire. And if it's acceptable, fix the fracture, do an arthrogram, insert some dye, check for the reduction articular congruity. And if it's acceptable, then you can go ahead and accept it. And this is a child who was treated this way. That's after fixation, and that's after healing, and that's range of motion. For the more displaced fractures and the ones which are rotated, it's a straight off open reduction fixation for me. I place the patient supine on the table. Child's got a tourniquet. You take a lateral approach. It's really easy to enter the fracture just as you cut the skin and the subcutaneous, you are in the fracture. You want to be gentle with your dissection, clear the hematoma, irrigate the joint, expose the fracture anteriorly, and you want to really limit your dissection on the posterior side because that's where all the vessels are coming from. You want to untwist the fracture fragment, reduce it, and see that it's accurate reduction at the trochlear edge. You want to hold the reduced fracture with a claw or a towel clamp and then fix it with 2 divergent K-wires. And I typically leave the pins out of the skin and remove them at 4 to 6 weeks based on how the fracture is going to heal. So this is the same child. It was went open reduction and fixed with 3 K-wires, went on to heal. And that's the function at follow-up. Another approach for fixation of these fractures for the open reduction has been described by Mohan et al. This is a posterolateral approach. I've used it in a few cases, but I encountered a little higher incidence of avascular necrosis just because of the way we put the clamp. It's in the olecranon fossa, and that's the place where all the important vessels are coming from. So I've discontinued using that, but it's an approach which gives you good exposure. And in their publication, they've reported no avascular necrosis. So just looking at some of the other factors that we need to consider, what's the best pin configuration? You want a divergence of about 60 degrees. And for the more unstable ones, you want to put 3 pins. Should we bury the pins? And this is a meta-analysis on this. And really the problems that we think of are infection with the pins when left outside. When should we remove the K-wires? Whether, especially if the fracture is not healing, whether it will require a reoperation if you bury the pins in, and whether it predisposes to delayed union. And it's really been found that leaving the K-wires out of the skin is safe and does not cause any problems. And that's what I do in my practice. So when should we remove the wires? And it's actually, the answer is when the fracture is healed, and you want to get healing across the fracture, not just the metaphyseal side or the periosteal callus that you see. That's not enough. You want to see fracture healing across the fracture fragment as well. So this is at 6 weeks, you can see that the fracture is now starting to heal, and that's when the wires come out. And the other thing that we want to look at is, should we use K-wires or should we use screws, and what's better? So for the older child who's got a large metaphyseal fragment, and especially those ones who have a delayed presentation, you probably would be better off using screws. This is the child who had a screw fixation. And when we look at screws versus K-wires, the screws are more solid as a means of fixation. When we use a screw, it should be a metaphyseal entry. It should be a partially threaded screw. You want to position it just above the olecranon fossa and get a bicortical purchase and use a washer as well, so that it doesn't get buried into the bone and it's easy to take out later on. So numerous complications are associated with this fracture. Delayed union, non-union, malunion, spurs, cubitus varus, valgus, fishtail deformities, and growth disturbances. We'll quickly look at these. The non-unions and the delayed unions are probably the most problematic of the complications, and they're because the fracture is intra-articular and it's being bathed by synovial fluid. There's poor blood supply, there's lack of proper immobilization often, and there's a constant pull by the muscle attachments, and there may be soft tissue interposition as well, which may be causing the non-union. The non-unions are classified as early or late, depending on whether they are less than 12 weeks or more than 12 weeks. And those with angular deformities or without the angular deformities. The ones without the angular deformities are often asymptomatic and they have minimal fragment displacement. Those with the angular deformity are often symptomatic and they have progressive deformity. So the delayed presentation, which is less than 12 weeks, it needs to be treated or it will predispose to non-union or malunion. This is a child who had this X-ray at presentation. He was put in a plaster. After 1 week, there was slight displacement. The surgeon thought was probably going to go on to heal at the cast. The cast was continued. This is at 4 weeks, and he wasn't still sure whether it's healing or not. There was some callus on the lateral side and the posterior side. So he just decided to allow the child to mobilize, and it went into a non-union. And this child had about 10 to 90 degrees of range of motion and was treated by a percutaneous screw fixation and went on to heal nicely. And this is a study which kind of tells us that these fractures are best managed by a percutaneous screw fixation, and you don't really need to open them. So this is at 6 weeks, this is at 3 months, that's his function. And the jury is out on the early non-unions without proximal migration and deformity. You just want to fix them with the screw and leave the articular incongruity alone. And open surgery definitely will carry a risk of stiffness and osteonecrosis, and you don't need to do that. So the late non-unions, the treatment is based on deformity, pain, instability, or neurological symptoms, and it's a la carte kind of approach. This is a 12-year-old girl, more than 5 years from injury. There was significant deformity and ulnar neuropathy on NCV study, and there was terminal restriction of range of motion. So there are two options. One is to fix the fragment only if there's pain and instability, ulnar nerve transposition for neuropathy, osteotomy if there's a valgus deformity more than 20 degrees. And two approaches have been described. There's a two-stage approach in which the first stage you go and fix the fracture and do the anterior transposition, and second stage do the osteotomy. The two types of osteotomies, there's the angulation and the angulation translation. We really want to do the angulation translation because you don't want to leave a secondary deformity. And there's a second approach, which is a one-stage approach. You do everythin in one go, in which you do an in-situ fixation, dome osteotomy for correction of the deformity and anterior transposition of the ulnar nerve, all via the posterior approach. So this girl underwent the one-stage procedure. There was a dome osteotomy, in-situ fixation, and anterior transposition of the ulnar nerve. That's how it was fixed. The K-wires came out after about 5 weeks. The fracture went on to heal. That's a correction of deformity, and that's a range of motion at 8 months. She has some restriction of flexion. That's another case, about 2 years non-union, and again fixed with screws and dome osteotomy. That's his function after 10 years. And so what we need to know is what to expect with reconstruction. So there's if there's instability and pain, they will typically resolve. The ulnar nerve symptoms resolve. The range of motion increases when the range of motion is restricted, but may have some restriction in long-standing cases and when you do combined procedures. The Milch type 1s have worse prognosis. A younger child has a better prognosis. The lateral spur, again, a common complication, probably the most common complication seen in almost all the cases. It's secondary to periosteal new bone formation, secondary to fragment displacement. And it can be seen whether you operate or you treat them conservatively. You may see a bony spur. It's usually not very significant, but if it's large, it can add to a pseudo-varus kind of deformity, which we'll see later. So the cubitus varus, I haven't encountered that in my practice at all, but about 40% incidence has been reported in literature and results as a malunion or overgrowth of the lateral condyle. It's usually not of great clinical significance, but you may want to be aware of it and may warn the patients that they may have some secondary deformity. So this is a child who had a screw fixation, and that's the kind of overgrowth of the lateral condyle, which causes pseudo-varus kind of a deformity. So the cubitus valgus, as we saw in the non-union, is mostly after a pseudoarthrosis, and the physiological valgus of the elbow during growth actually predisposes to this and causes more shear and progressive deformity. And in literature, more than 10 degrees of the physiological valgus can predispose to tardy ulnar nerve symptoms, which may occur even after 10 to 15 years of the deformity. And so we want to be aware of this and warn the patients. The fishtail deformity is really a peculiar deformity, which is pertinent to this kind of a fracture. Two types are seen. They may be visible as early as 1 month from the fracture. There's one which is the sharp angled wedge, as we see in this photograph. It's secondary to malunion. And the gap between the trochlea and the capitular centers can produce a malunion and a physeal bar and cause this kind of a sharp angular deformity. The other is the gentle curve. It's secondary to AVN of the lateral part of the trochlea. Clinically, actually, both of these are quite insignificant and really require no treatment as such. Growth arrests have been reported, although they are not very symptomatic because there's hardly any growth remaining from the lateral part of the distal part of the elbow. But we need to be aware of it, and cubitus varus from the overgrowth actually sometimes just compensates for the growth arrest if it occurs. So in summary, we want to get an internal oblique view of the elbow. We want to follow the minimally displaced fractures closely to check for secondary displacement. For the minimally displaced fractures, you want to do a close reduction arthrogram and pinning. And for the more displaced, I just go and do an open reduction. And follow-up is essential to monitor for all these complications that we just talked about. Thank you very much.
Thank you, sir. So it was really a comprehensive overview of lateral condyle fractures. So next, I request Dr. P.N Gupta to start sharing his screen. His topic will be Monteggia fracture dislocations, avoiding pitfalls. And I know that this topic is really close to his heart.
Sorry, thing was muted. Is my screen visible?
Yes.
Yeah. Am I audible, please?
Yes.
Okay.
Yes, sir,
So-
you are audible.
So good evening, everybody. This is an 8-year-old girl, the fracture of the ulna. So there are a lot of confusions with the diagnosis. But what we know from our basic training is that one has to screen one joint above and one joint below. That's the basic training which all of us have. So basically, this patient had a ulna fracture, but need to factor in the dislocation. So I'll come to the topic as we discuss the thing in more detail. So overview is that one has to avoid pitfalls in identification, how to avoid pitfalls in identification. Then management principles of acute Monteggia fracture dislocation, and then we will discuss about the chronic Monteggia lesion. So Monteggia has been described by Monteggia way back in 1814, and it's a fracture with a fracture of the ulna and a radial head dislocation, and it's seen in both adults and children. Now, if you see the anatomy of the forearm is both the bones of the forearm are held together at the proximal and the distal end with radioulnar joints and the ligaments, and they form an intricate relationship like a square. Now, if one bone fractures, let's say the ulna fractures, and it is undisplaced, the radius remains in place. But if the ulna displaces, either the radius fractures or there is a dislocation by disruption of the superior radioulnar joint. And this is what a Monteggia lesion is. So any patient where there is a displaced fracture of the ulna, one should be very careful with the radial head dislocation. Now, Monteggia described, or Barrow described 4 types of Monteggias depending on the force direction and the fracture pattern. So it's very simple. If you see this diagram, this is the ulna, this is the radius. It can go anteriorly, it can go posteriorly, it can go laterally, it can't go medially. So please remember 4 things. So type 1 is basically once the radial head goes anteriorly. So this constitutes about 70% of the cases. And the basic management is you have to align the ulnar fracture and the radial head, it falls in line. But one must remember that biceps pull may redislocate the radial head. So to neutralize that, one has to immobilize the elbow in about 120 degrees of flexion. Type 1, this is the closed reduction. If it remains stable during anesthesia, you have put it cast. If it is unstable, you might require a pinning or plating depending on the age of the child. It's your choice. Type 2 are about 6%, and it's a posterior Monteggia where the dislocation of the radial head is posterior. So basic treatment again still remains the same, close reduction and slab or cast in about 60 degrees of flexion or extension depending on where the radial head becomes stable. But if it is totally unstable, one needs to fix it either by close reduction or by open reduction as the case may be. Younger child, you use K-wires. Older child, one tends to use plate and screws. And here, if you appreciate this posterior dislocation of the radial head, it was unstable. and it has been reduced by 2 K-wires by close reduction. Type 3s are basically lateral Monteggias with where the force is from medial side like this. And they are little unstable fractures. So the tendency for the close reduction and the casting would be, I mean, the threshold for open reduction should be a little lower. So close reduction, you use a varus force, lateral pressure on the radial head, and if it remains stable, you put in a cast. But if it is unstable, then you put in a K-wires as deemed necessary, or you put in a plate and screws if the child is older and the fracture permits that. Type 4 are very, very uncommon, less than 1%. So it's a fracture of both the bones of the forearm with radial head dislocation. So the treatment is basically you treat the forearm by close reduction and intramedullary pinning or open reduction and plating as the case may be. And a lot of times you're able to do a close reduction of the radial head dislocation. If it fails, then consider an open reduction. What if the radial head is not reducing? Consider a annular ligament interposition. So unstable radial head is mostly due to interposed annular ligament. And in this situation, you have to excise the annular ligament to get the reduction now. How to avoid pitfalls? One has to recognize atypical presentations. That's like a radial head, isolated radial head dislocation. And mostly this is because of the plastic bowing. And a lot of people will mistake this for a strain of the forearm. How do you recognize that? Is the ulnar bow sign, where if you draw a line from the ulna proximal to distal, it should run all along the border of the ulna. So ulna should be a straight border. Ulnar border of the ulna should be a straight border. But if it is not a straight border, then one has to be very careful with the plastic deformation. And the second line is the radiocapitellar line, where if you draw a line from the radius, it should bisect the capitellum there. The second atypical presentation is a fracture of the ulna along with a fracture of the radial neck. So there are a lot of variants of Monteggia described. I'm not going to go into the details of each of them. But the common type 1 variants where there is a fracture of the radial neck along with the ulna. Try a close reduction. A lot of times you're able to do a close reduction. If it fails, then consider a open reduction. So again, type 1 variant where there is a fracture of the radial neck. And again, there is now why there should be a missed Monteggia fracture. A lot of times we have seen that the Monteggia fractures are missed. So many misdiagnosed Monteggia fractures are because of the distracting injury of the ulna, where person thinks that there is isolated fracture of the ulna. So the dictum is that any isolated fracture of the ulna, one should consider it as Monteggia unless proven otherwise. The second thing what you can see apart from the ulnar bow sign is the radiocapitellar line, as we discussed earlier. So any view which you take, a line drawn through the long axis of radius should cut the capitellum in the center. That's the ulnar bow sign. You can appreciate the dislocated radial head also, and you can appreciate the bowing of the ulna also. So first carry home message. All isolated ulnar fractures should be considered as Monteggia lesions unless proven otherwise. So Monteggia fracture dislocation. Two things you must see: radiocapitellar line. Draw a line in the long axis of radius. It should bisect the capitellum, and the ulna should not be bowed. Most fractures, they respond to close reduction and casting, but if they are unstable, consider internal fixation, either close reduction and internal fixation or open reduction and internal fixation, as the case may be. And open reduction of radial head in case of irreducible radial head. I come to the chronic Monteggia lesion. Most of the chronic Monteggia lesions are because of the missed Monteggia lesion. That means one has missed the radial head dislocation. So presentations could be loss of flexion, limitation of pronation supination, a valgus deformity, a varus deformity, and the X-rays, they may look a little weird, or prominence of radial head and pain in that prominent radial head region. The logical thinking is, well, you should reposition, but there was this article in 1956, way back in 1956, which says that this doesn't cause a significant disability. So why treat it? But the concern with the chronic dislocation, as seen later, is that the short-term results may be good, but the long-term results are poor and leads to stiffness, deformity, pain, instability, cosmetic issues, and sometimes tardial nerve and radial nerve palsy. So pathological changes in untreated Monteggia can lead to distal humeral dysplasia, proximal radial dysplasia, long-standing cases sometimes distal radial nerve joint subluxation, and pain and degenerative arthritis as well. But question is reconstruction successful? If you see these papers from late 90s, early 2000s, lot of them, they have bad results. So let's see what happened later. In late 2000s, the long-term clinical results of open reduction were much better, especially if the age was less than 2 years and the dislocation was less than 3 years old. And ulnar osteotomy with ligament reconstruction gives a good results, as reported in Journal of Orthopedic Trauma 2006. So now the current consensus is reconstruct wherever it is possible. That means you need to reposition the radial head back. For that, you need to understand the pathophysiology. So forearm bones, as we discussed, they are intricately related. But if there is a malunion there, there is a shortening of the ulna and angulation of the ulna. So restoration of the length of the ulna and the bow of the ulna and maintaining that with a plate and a stable fixation, that will realign the radiocapitellar joint. And this has to be maintained by a stable reduction and fixation. So surgical steps are expose the radial head, do an appropriate angulation, lengthening, osteotomy, and a lot of times the radial head falls back. In case it doesn't, then you need to go in for open reduction. So this is a plastic bowing. Again, you need an angulation, osteotomy. And where should the osteotomy be? Is it good? No, it's not good. The radial head is still dislocated. So despite so much. So why the radial head should be still dislocated? Because one has failed to remove the thick fibromeniscoid tissue interposed there. One must remove this. If one fails to remove this, then there can have problems in radial head reduction. Some technical tips and controversies. Where should be the level of osteotomy? Not distal, but proximal. Why? Because of the greater reduction force proximally and more chances of preservation of the forearm rotations. How much to angulate? Mild overcorrection gives a much better result and decompresses the radiocapitellar joint and leads to lesser chances of stiffness. Should you reconstruct the annular ligament? Well, perhaps. If it is not always required. This was an article, well-quoted article from 2009 by Bhaskar et al. But if the radial head is unstable, despite your ulnar osteotomy, you can consider reconstruction. If it is still unstable, you can pin the ulna to the radius, but never do a transcapitellar pinning. If it breaks, it's a problem to remove. When not to reposition? Misshapen radial head, usually more than 3 years old. When in doubt, take a contralateral radiograph or do further imaging for that. Resection of the radial head, usually not done unless it is highly symptomatic. And especially if it is nearing scalpel maturity, you can consider, but routinely it is never done. So the second carry-on message is for chronic Monteggia, ulnar angulation and lengthening osteotomy, radial head reposition only if the radial head is not out of shape. Annular ligament reconstruction not routinely required, but you can consider if the radial head is unstable. Thank you. I'll stop.
Thank you, sir. So it was also a very comprehensively covered topic. So next, Dr. Nirmal will speak on forearm fractures in a child, cast or operate.
Good evening, everyone. Is my slide visible?
Yes, yes.
I'm audible. Thank you. So my topic for discussion is forearm fracture in a child to cast or operate. I thank the Uttaranchal Orthopedic Association for having me here. I have nothing to disclose. So do we have a debate whether to cast or to go for an open reduction and internal fixation in a forearm fracture in a child? Because many times we try to use the principles used in adult trauma here directly. Because in adult trauma, it is taught to us that forearm should be considered like a joint and you always require an anatomical reduction. But I give the verdict also here. Many of the forearm fractures in children can be managed non-operatively in a cast, if you know some basic principles. That's the main thing we have to understand here. You need not open and reduce every single fracture coming to you. So let's go through a few things, how a child is different from adults to know why you have this difference, the type of fractures, and a few management principles. So why do we have to know this? Because what's more important is what we are going to lose if you are not going to manage them in a proper way. So here is a 15-year-old female with a 2-month-old injury treated by a traditional bone setter. So the bone has united, but it has malunited. And so what's the problem here? So this is the range of motion, what she has now. So there is limitation of supination as well as pronation. And this is the end result, which happens if it is not treated in a proper way. So that is more important. So as I told, children are not small adults, and we have few basic things which has to be understood. So kids have a growth plate. So I will use my laser. Yeah, kids have a growth plate, and that is going to play a major role in management, because 80% of growth of a distal radius is going to occur distally. And anything that is going to happen distally is going to be forgiven to a maximum extent. Whereas proximally, we don't have much of the remodeling potential or correction. So that we have to be very careful here. And other thing, Dr. P.N was also talking about a plastic deformation. So why does that happen? The children's bone is more porous, and you know that a compact bone. So for example, if you consider this yellow one to be a bone and try to bend it, so it is going to fail in tension in an adult. That's on the convex surface. Whereas in a child, because of the porosity, it's going to fail in the compression side also. That's here, the concave side. So what does it lead to? So there are peculiar fractures to the child. One is a plastic deformation or a smooth curve, as shown in the top one. There can be a buccal or torus fracture or a green stick fracture, apart from the complete fracture, which we come across in adults also. And as I told you, you should also remember the remodeling potential, which is more in a young child and which is more when it happens distally compared to the proximal aspect in an older child. So what are the things that are going to determine how we treat them? First thing is the completeness of the fracture and other aspects like the level of injury, the angulation or displacement, and the age, which are all taken together. So this is a graph of stress versus deformity. So here you can see that when a bone is stressed, there is an elastic zone. When you try to bend it, there is an elastic zone where when you remove the stress, it's going to go back to the normal shape. But when you further bend it, it's going to go into a deformed state without getting fractured. That is the plastic zone. That is what we were talking about. That is the cause of a plastic deformation in a child. So here in this child, you can see that the radius has a macroscopic fracture line, whereas the ulna doesn't have a fracture line, but it is smoothly curved. So this is called a plastic deformation. It is because of multiple microfractures along the length of bone. Now coming to the treatment aspect, do we have to treat these fractures? So like it's an intact bone, that's the question. But you saw in the previous presentation also, there is a plastic deformation which altered the radiocapitular alignment also. And here also, this much of deformation in a subcutaneous bone is going to cause a cosmetic defect, as well as it is going to hinder your pronation and supination. So what is the threshold for acceptance here? So according to literature, it is more than 10 degrees of deformation in a child who is more than 6 years of age. But to keep it simple, when you have a well-looking or a straight limb with no limitation of pronation and supination, then you can accept a plastic deformation. Remember, it's not going to remodel. Whereas if it is going to alter the pronation and supination in an older child, then you have to go ahead with a reduction maneuver, which is like a constant pressure applied across a fulcrum. So it's a huge amount of pressure. And the most important thing is you have to sustain it for several minutes. So if you put pressure and just remove it, when you see a straight bone, it's going to bounce back. So you have to sustain it for at least 3 or 4 minutes to get the sustained correction. And then when you are satisfied, you can take off the pressure. If you are not able to correct it within normal limits, which happens very rarely, then you can go for osteotomy, but it's very, very, very rarely required. So next comes the green stick fracture, which is again peculiar to children. Here you have an intact cortex and a cortex that has broken here. So what's the importance of understanding a green stick fracture? So if you go through an article by Evans in 1951, it has been clearly explained that the angulation which you see in a two-dimensional radiograph is a combination of angulation and malrotation. So why should we know that? Because the fall on an outstretched hand has an axial component, that is the loading component, as well as a rotation component. So when there is a supination type of injury, the apex is going to be on the anterior aspect or volar aspect. And when there is a pronation type of injury, the apex is going to be the opposite one, that is on the dorsal aspect. So if we understand this deforming force, then the reduction maneuver becomes very easy. You have to reverse the forearm rotational forces. For example, in this injury, you have to pronate, and if it is the dorsal apex injury, you have to supinate to get a reduction. So the next common question that is always asked is whether to complete a green stick fracture or not. So there are proponents like to complete it because a complete fracture, a thicker callus is thrown and there is less risk of refracture. But as we saw, there is a rotational component and always there is a risk of recurrence in the immediate period, reduction period. Whereas if you go through the article by Evans and further literature, you can see that there is an inherent rotational component. So if you derotate it, there is less chance of recurrence of the deformity, and you are not compromising the stability by breaking it. But those who are against it say that there is a poor callus formation and there is a more chance of refracture. But nowadays, we tend to derotate it more than completing the fracture. Another one you have to remember is how to assess the reduction if you're going for a derotation maneuver in this. So the one thing that is useful is a radius crossover sign. So you can see the position of radius, like in a supinated limb, it is not crossing the ulna. In a mid-prone or in a neutral position, you can see that it is crossing the ulna in the junction of middle third, distal third. Whereas in a completely pronated arm, you can see that it is crossing the proximal third. So how is it going to be of help? So here you can see in this picture that, as I told you, in a completely pronated limb, you can see that it is crossing in the proximal third. But when you see the distal morphology, you can see that this is not the morphology which you see in a completely pronated limb. But this is one that is mal-reduced in rotation. So you have to see a picture like this. So now you can know that there is a mal-rotation which has to be addressed. So this is how it is going to be of help. Now come to complete fractures. What are the possible deformations because of the attached muscles? You can have angulation, rotation, translation, and shortening. So this is a complete fracture in the proximal third of the radius and the midshaft fracture of ulna. So again, this slide is repeated. So what are the treatment determinants? It's the level of injury, the angulation or displacement, and the age, all of them taken together. So The most important thing in these fractures is you have to regain the interosseous space when you attempt a close reduction. This is very important because narrowing of the interosseous space, and that too in a proximal fracture, is going to impede the rotation and thereby reduce the pronation and supination. So in this child, you can see that the interosseous space is invaded and or reduced, and you can see that there is a limitation of pronosupination. Regarding angulation, yeah, again, the angular reduction or the alignment is also very critical for preservation of forearm rotation. And you can see that there are many studies which are able to prove that higher degrees of residual angulation, especially in the proximal forearm, leads to greater restrictions in the supination and pronation. If you see, this is a normal limb where the radius is going around the ulna, and this is the normal range of motion. But as where an angulated malunited fracture, the arc is going to start from here and is going to go up to this point, that is B dash only. So you are losing this much amount of rotation here. The more proximal you go, the more proximal you are going to lose the rotatory movement. So that is why we have to be very careful in proximal fractures. Whereas in distal fractures, we saw that it is a bit forgiving, and this kid had an excellent range of motion, and we had accepted this reduction when we got it. So as I told, this paper is a landmark paper by Charles Price, which combines all of them, the level of injury, age, and angulation, and gives a chart using which you can manage these injuries, whether it is an acceptable reduction or not. So the watershed is like an 8-year, and the acceptable rotatory reduction is less than 30 degrees because rotatory remodeling is very less, and you cannot expect the rotation to remodel to a larger extent. So proximal third fractures have lesser threshold, and they demand near anatomical reduction for better outcome. And this acceptability criteria almost remains the same for all these years. And one thing, when you are assessing the angulation, you have to be very careful, because if you are going to see an angular bone in both anteroposterior and lateral view, it means that the deformity is in another plane. So what you need to get is in one view it should be a straight bone, and the other view should be 90 degrees to this straight view, and this one will give the amount of angulation that is present in the bone. So if you have an angular deformity in both the views, you may be underestimating the angular deformity, and that may have an impact on your management option. So as I told you, rotational malalignment is very poorly tolerated, and we do not accept more than 30 degrees of rotatory malunion. There are also landmarks, bony landmarks, which can be used to assess your reduction. For example, the bicipital tuberosity and the radial styloid are placed in a way that they face opposite side, like they're faced like 160 degrees away from each other. So in an X-ray, if you see the bicipital tuberosity and the radial styloid on the other facing from each other, then it means that it's a good reduction. So here you can see this is the bicipital tuberosity and the radial styloid, and it's a properly reduced fracture. Other thing is a bayonet apposition. It does not limit rotation. It can be accepted unless otherwise the other angular measurements are acceptable. Shortening, according to Price, helps in maintaining motion because it relaxes the interosseous membrane, but we do not accept shortening of more than 1 centimeter, be it a single bone fracture or a both bone fracture. So these are few case examples. So this is a child with a supination type of injury, because you can see that the angular apex is anterior. So what we did is a pronation and a bit of 3-point bending, and you can see that the cast is given in pronation, and this went on to heal well without any restriction of range of motion. So this is a child, 10-year-old child, and you can see that there is a radius fracture. But if you closely observe, you can see that there is an angular deformation, a smooth curve in the ulna also. So this child has both a plastic deformation as well as a fracture of the radius. So we did a close reduction, and you can see that there are few points in a cast which you have to be kept in mind. The cast has to be molded in such a way that you get an elliptical cast. You can see this diameter here of the inner diameter of the cast is more than what you see here. So if you divide this one by this one, it is going to be less than 0.8. That's the cast index. You should have a straight ulnar border. You should have a uniform layer without much gap in between. And you should have a proper 90-degree bend in the elbow without any crevices. So if you have a good reduction, then it's going to heal with a good outcome. This is a child who was referred after 2 weeks with a failed reduction, and you can see that there is a proximal radius fracture as well as a diaphyseal fracture of the ulna, which is not acceptable in a cast here. And this is 2 weeks old, so we had to go for a open reduction and internal fixation with a titanium elastic nail. So to conclude, as I started, most forearm fractures can be managed non-operatively. So you need not go and operate every forearm case that is coming to you. The acceptability criteria should be kept in mind. We know the watershed, that is 8 years, and the acceptability criteria. Remember, the rotational mal reduction is not going to remodel. Apart from that, other fractures in the distal third are forgiving other mal reductions, and the proximal third, we have to be very careful because it may invade the interosseous space and reduce the movement. So I thank you all for giving me the opportunity. Thank you.
Very good this presentation. So we learned a lot of new things. So now I'll request Dr. Dhiren to start with this lecture on fractures of the distal end of radius in children.
Yeah, whether my slides are visible?
Yes, sir, they are.
Yeah, perfect. So in this presentation, I am trying to give you some case discussion points, and from that we will learn about the management of fracture radius. Sir Richard Branson, a very famous industrialist, said that anyone can make things complicated, but very few can make things simple. And in this presentation, I will try to make it as simple as possible. So let's start with a case one. He's a young doctor. He presented with a boy, 7-year-old, girl, with a fracture metaphyseal area, which is displaced. He carried out reduction, and he was happy with the reduction at that point. And he said that the child requires reduction under anesthesia. After a few days, he went for the check X-rays, and that shows this position that fracture has redisplaced in spite of the satisfactory reduction he had on the table. He measured the angulation, and angulation is around 32 degrees. So now the question with him is like, should he try reduction or should he accept? He suggested to the family that this requires remanipulation. And because this requires general anesthesia, again, the family was reluctant for that. And they decided to take the second opinion. They went to one senior orthopedic surgeon and showed the X-rays. And that senior orthopedic surgeon said that, don't worry, this amount of angulation will get corrected. So family was very happy. And this was the situation at 2 months, and this is at 7 months. So when this gentleman, the first orthopedic surgeon, came to know about this, that in a case where he suggested remanipulation, the other orthopedic surgeon said that this can heal well, or this will remodel, and it remodeled. So he realized that this is a time to update myself. And he decided to attend webinars like the current webinar of Uttaranchal Orthopedic Association. So in that webinar, he learned that one senior professor from Malaysia, Professor Soek, lecture. He saw that in a girl almost the same like the previous one, 8.5-year-old girl with an angulation of 42 degrees at the distal radius level, which remodeled to 25 degrees in 9 months. And in 19 months, it came to 11 degrees. So the point is, there is a significant remodeling capacity at this area. So from that, he learned that remodeling is very good, particularly when child is less than 10 years. So now the question is like, if he present with a second case like that, how much angulation can be accepted? So he came across a very good article in Curious Journal, that's 2018, Conservative Follow-up of Severely Displaced Distal Radius Metaphyseal Fracture in Children. And that article gave a broad outline that if child is less than 10 years, we can accept up to 39 degrees of dorsal angulation, up to 22 degrees of volar angulation, and 30, almost 40 degree of radial angulation. So both dorsal and radial angulation up to 40 degree can be accepted and they remodel well. If child is over 10 years and under 15 years, where we know that they are coming to the end of the growth, and at that point, the remodeling capacity is less than the younger age. So dorsal angulation up to 38 degree can be accepted or remodeled. Volar angulation again up to 16 degree. But here the radial angulation, which was previously up to 39, here it's only up to 23 degree can be accepted. So the lesson which he learned is like we need to take advantage of remodeling capacity and we can avoid the repeated remanipulation. I don't want to say that don't reduce. What I am trying to say that try to reduce as good as possible. But if it displaces and if it is within the range, then we can rely on the remodeling capacity. The most important practical point is like family members, they always have a tendency to look at X-rays and they don't know about remodeling. So at this point, if we really want to go for this natural remedial forces, then we need to have a good communication with family. That's a very important thing. Coming to the second case, after a year, another child in the same family was going for a very aggressive game and she landed on a forearm, on the wrist, and there was a fracture. So now family had two options, which orthopedic to suggest. The first one, the one who suggested remanipulation, and the second senior one who suggested continue the same treatment, and the child got a very good result. So this time they decided to go to the senior one where he avoided the second anesthesia. So now he took the X-ray. This is a 10-year-old girl, and there is a fracture with a 1.4 centimeter overriding. So now the various options for treatment are closed reduction and cast, closed reduction and K-wiring and cast, open reduction and K-wiring, open reduction and plate, or something else. So these are the options. For the sake of time, I will not go into the discussion at this stage, but senior doctor suggested that I will go for the closed reduction and casting. But the child may require open reduction if closed reduction is not possible. Family was worried about anesthesia, so they decided to go for a second opinion. And this surgeon said that let me have a very different approach. He said that in the approach which I want to suggest, I am not going to give any anesthesia. I will not try to correct the overriding, means I will not give a longitudinal traction. I will not try to reduce it. I will just correct the angulation and give a short-term cast for 6 weeks. A very different treatment than conventionally what we are taught. So this is a fracture. He gave a cast, he corrected the angulation, did not try to correct overriding. This is the short-term cast. The child was very happy. This is at 6 weeks. This is at 1 year, the complete correction. Now we would always say that one swallow does not make a summer. So here is the more definitive proof. An article published, a very landmark article published in Journal of Bone and Joint Surgery in 2012, the close treatment of overriding distal radius fracture without reduction in children. This article got the best paper prize in Journal of, in POSI meeting. So in that article, there were 51 patients, the metaphyseal fracture with bayonet positions. The age was 3 to 12 years. Approximately average age was 7 years. The overriding was in the tune of 1 to 14 millimeter. The procedure, as we discussed, no anesthesia, no attempt to correct overriding, correct only angulation, short-term cast for 6 weeks. What is the follow-up? At 1 year follow-up, the patient did not have any pain. There was no tenderness. There was no non-union. The wrist range of motion was full, and the grip strength was also normal. The angulation in sagittal plane was 4 degree, in coronal plane around 3.2 to 1 degree. The question which always you would be like to ask, what about the overriding? There was a neutral ulnar variance, means there was no major difference in the limb length or the length of the bones. And parents were satisfied with outcomes. All the 51 patients in that series, the parents were satisfied with outcome. So the important message of that paper is, in a less than 10-year-old child, the bionic reduction is acceptable. Short-term cast can be given without anesthesia. We just need to correct angulation. So that is a very important message, that we don't need to go for close reduction under anesthesia in all the cases. Coming to a different type of case now, the case 3. This is again a angulated fracture, almost like the one which we showed. Here we can see that there is a dorsally displacement. So there are various reduction techniques. The first is like we overangulate, and then we give a longitudinal traction as shown as a red arrow. And whatever overriding is there, we correct it. And once that is corrected, we correct the angulation. So that is the procedure which we carry out. Another method is a joystick technique, in which we pass a small blunt K-wire in the fracture gap. We use this K-wire as a joystick and try to correct like this. And with the help of this guide wire or a joystick, we reduce the fracture. So these slides are from my colleague, Dr. Mandar and Dr. Sandeep from Mumbai. So these are IITV image, the fracture which is displaced. The K-wire is trying to enter into the gap. Now the pin is inside the fracture gap. Now this pin is rotated and towards the distal fragment. So this is how it tried to buttress the distal fragment, and at the same time it tried to reduce. And this is how the complete reduction is achieved. Once the reduction is achieved, this pin is removed, because this pin is only for getting the reduction. So the various methods for reduction are longitudinal traction, overangulation, joystick method, or ultimately if none of the technique works, then we can go for open reduction. The next question we want to discuss is, after reduction, should we pin or not? There are various factors which leads to redisplacement, and this is based on the meta-analysis published in 2019. So that meta-analysis suggested that when there is a complete displacement, there is the chances of redisplacement, and so it is better to go for pin fixation. When there are both fracture radius and ulna, the chances of redisplacement are higher, and it is better to fix. The next question, whether to pin it or not. So based on that, the completely displaced metaphyseal fracture of the distal radius in children, unpinned group has 7 fractures out of 33 displaced. So you would definitely suggest, if the large number of patients as displaced, then we should definitely go for fixation. But on the other end, in the pin group, 0 of the 35 fracture displaced. So definitely pinning has an advantage, and it definitely reduces the chances of displacement. So the cast immobilization versus percutaneous pin fixation for displaced fracture. The 39 treated with casting required remanipulation. But on the other end, 38% of the patient in a K-wire group had implant-related issue. So on one side, we are trying to get a fixation by pin, but at the same time, we need to remember that it increases the chances of K-wire related complications. So based on my understanding of the problem, the indications for pinning are completely displaced fracture, a comminuted fracture, when age is more than 12 and the chances of remodeling are becoming less, or there is a fracture of ulna and radius both. In that case, we should go. Now, the next point is, will you reduce pin radius? And if yes, how many pins? So let's say this is a fracture. One possibility is like we pass through the styloid and fix it like this. And the second is we pass two wires like that and we avoid the physis. So this is a very common situation because the second option is safe, but it's difficult to carry out. While the first one is very easy because the direction when we achieve from the distal radius, we can fix the fracture very easily. A very good article which tries to evaluate what happens when we pass a pin across the physis. Does it lead to any physeal damage? It is MRI evaluation in a very small number of patients, 5 patients. After 3 weeks of the pin removal, they suggested MRI. And in none of the patients, there was any signs of physeal bridging. So this author, they suggested that if you take care of the precautions, which I'm going to show in the next slide, then a pin passing through the physis does not cause problem. And what precautions we need to take so that we avoid physeal damage? We need to use a sharp K wires. It should be as thin as possible, preferably less than 2 millimeter, and we should pass it in a single attempt. So with that, I stop my presentation, and this will basically give us some idea about the practical tips for this fracture. Thank you.
Thank you, sir. Thank you very much. It was a very nice presentation. So now I will request the panelists to, if there are any questions, now is the time to ask them. So among the panelists, we have Sirohi sir, Dr. Durga.
Dr. Chetan, one question.
Yes.
If for lateral condyle fracture, to Dr. Kapil, if we are dealing Mills type 1 in cast, so what should be the position of forearm in cast, in supination or in pronation?
So you, yeah. So one point before I answer that question is that it's uncommon fracture pattern which goes through the capsular ossification center. You hardly ever see those, but you want to dorsiflex the wrist to minimize the extensor pull on the fragment. That's probably the most important thing. And you want to maybe keep it in a mid prone. That's where I put it, in a mid prone and with the wrist dorsiflex.
So one more question to you, sir. Many times we are seeing that after the surgery, kids are developed peaking of the lateral end or widening of the physis. Is there any way to prevent this thing, or what is the exact age or indication when we should intervene in these cases?
So the beaking is actually what is called the lateral spur. And yes. It's actually quite common in over 80% of the cases. You'll see a bit of the lateral spur. Some children it's more, some children it's less. Just some things that can minimize the lateral spur is that when you're going in for open reduction, don't try and strip the periosteum too much from the metaphyseal side, because that kind of puts more reaction and can cause a bigger spur. But a little bit of it kind of remains, and some of it just over a period of time, it remodels also. So it will become less over a period of time. You hardly ever need to intervene for that. So you don't need to go in and, knock it off, because it probably might just predispose and get another spur after you remove it.
Thank you, sir.
Sir, my question to you, Kapil sir, is that we are sometimes faced with a dilemma whether this is a type type 1 or whether it is type 1 or type 2, or type whether the defect is complete or it is incomplete, the articulate hinge is intact or not. So how do we know whether the articular hinge is intact or not?
So the best way is to do an interval X-ray. So after about 5 to 7 days after the initial injury, you just remove the plaster, get AP lateral and internal oblique AP view, of the elbow out of the plaster. And then you see for any interval displacement of the fracture. So the fracture is displaced, then it's definitely a complete fracture and it is unstable and you need to stabilize it. And if the fracture is not displaced in about a week's time, then it's going to remain where it is and chances are that it's not going to displace. So those are the ones which are with the incomplete articular fracture. So that's the practical way to do it. I mean, if you want a documentation, then you have to go through a MRI or ultrasound or arthrogram or some stuff like that. But that's actually impractical in these small children. So the best way to do it is to do an X-ray at about 5 to 7 days.
Yeah, I mean, I will. Yeah, I just wish to add one thing that in some of the centers, like my center or maybe perhaps Chetan, your center, where the patients may not be coming back again and again after a week because of some reasons, patient-related reasons, or your institute-related reasons. If you find a dilemma between the two, it's better to pin it there and then. Right? Otherwise, what Dr. Kapil is saying is absolutely correct. That you can actually have a X-ray again down the line about 5 to 7 days. If it displaces, then you go in for pinning. But if you think that the patient is not going to come back, it's a safer choice to pin.
There is one more dilemma, sir. When these patients they return after, say you have been managing them for a month, 2 or 3 weeks conservatively, and they return. So then you don't see any healing. So what would you do next? You would pin them in situ, or you would try to open them and curate the fracture site, or put some screw, or just you don't see any callus. You just see that the fracture line is there after 3 or 4 weeks.
Yeah, Dr. Kapil.
Yeah, so if it's not rotated or angulated too much, you can just push on the fracture, get it to align better, and just fix it with some percutaneous pin. So under in about a month's time, you said it's about what, a month out from injury? If
3 or 4 weeks. Usually they come
3-4 weeks. Yeah, within a month, you can just do a closed reduction and pin it. If there's a fairly decent metaphyseal fracture, those are the ones in which I'll just pass a percutaneous screw. That's what I do. I don't open these. Yeah.
Dr. Kapil, just I want to ask you, because sometimes you will get a patient will present delayed presentation and they will see very thin fragment, lateral condyle thin fragment. So just a KVR is sufficient, or we need to do bone graft at the same time?
Yeah, you don't need to do a bone graft. So unless, it's now rare to do a bone graft even in the non-unions, you just, if you're opening them up, you just freshen the fragment and you put some screws across it. It's enough to initiate the healing. And if you see a thin fragment, it's probably unossified. The fragment is usually a fairly big chunk of the lateral condyle. So in the young children, it appears as a thin wafer kind of a line, and the majority of the fragment is unossified. So if you put some dye in it or do an arthrogram, you'll see fairly large fragment size.
Okay, thank you.
So,
may I ask a question?
Yes, sir. Vimal sir, please.
Vimal sir, please.
This is about same lateral condyle. Open it. You always do program. Check on tape.
I'm sorry, I didn't get the question.
When you are doing reduction with fixation, do you always orthogram?
Dr. Kapil, I think what he's asking is that once you're doing a close reduction and pinning, do you always do arthrogram?
Almost always, yes. Almost always. It's so easy, you just from the posterior side, just proximal to the olecranon. What you do is you just stick a spinal needle, about a 20 gauge spinal needle is what you need. And then you pull the stylet out, you are in the fracture hematoma. And that's where you just inject some dye, it will just spread nicely and you can see the articular surface. But the thing is that you want to fix the fragment first by close reduction, and the arthrogram is only to confirm your reduction. So if you do the arthrogram earlier, it kind of, smudges the picture and you may sometimes not be able to visualize it well. So it's a kind of a confirmation for, that you got your reduction adequate. It's a rare that you will have to revise it. Usually what you do with your close reduction is adequate.
Question was, when you are doing open reduction, do you also do orthogram or not?
No, because then there's no sense. One, you are visualizing the fracture right in front of you, and if you put the dye, all of the dye is going to get washed out. So it doesn't work for an open reduction. For closed reductions, you do arthrogram. It's recommended. Yes.
Dr. P.N Gupta sir, I have two questions. One is how much angulation we can do in delayed presenting case to correct achieve the alignment of radial head, and other one is the how you are reconstructing an annular ligament.
Okay. Now, first question is how much angulation? The
Yes, sir.
primary thing what you see after you're doing osteotomy of the ulna is in how much angulation of ulna the radial head is stable. You add a couple of degrees more, maybe between 5 and 10 degrees. Do not over-angulate, otherwise this will lead to a cosmetic deformity. So a couple of degrees more, that will make your radial head more stable. Right. The second thing is, if you want to reconstruct the annular ligament, I have done it a couple of times. I have stopped doing it in most of the patients, but I have done it earlier. Use the center of the triceps fascia, aponeurosis. And that's the classical Beltaw's procedure, BELLTAWSE, Beltaw's procedure. So that you bring it here, you wrap it around the radius, and then suture it back. So this is how you reconstruct.
Thank you.
PN sir, my question is, when will you not do this radial head reduction? What is your cutoff limit for doing a radial head reduction in a missed Monteggia?
My cutoff is that if the radial head is deformed, and that you can pretty well make out on radiographs. If I have a doubt, I'll consider a CT. I mean, mostly if it is young child, I'll consider MRI, and older child, I'll consider a CT. Of course, you have the contralateral elbow X-rays to compare the things on. If you have a misshapen, then I will not consider, because they don't succeed.
So there are certain scenarios, like sometimes a patient comes when he doesn't know exactly since when the radial head has been dislocated. And then X-rays also, they are not very clear whether the head is that much deformed or not. So how do you proceed in those cases?
I mean, a lot of times these are cases with plastic bowing, perhaps, what you're talking of. So, I mean, if you have a doubt, consider further imaging like MRI or CT, whatever you deem is necessary, depending on the age of the child. Younger child, MRI. That will give you a radial head shape reasonable. And if it is reasonably in shape, you consider a repositioning. If it is out of shape, then, I mean, and of course, X-ray will give you a lot of information as well.
What would you do if you think that the radial head is deformed? If you
it's better to leave it as such.
But then they have other problems like cubitus valgus also. Some have tardial.
Yeah, they have, and then when I mean, like if they have a problem later on, then you can tackle that problem at that point of time. Most of the people who will have problems, they will have problems very early on, and they tend to present very early on.
Yes.
The ones which are presenting later, especially the pain in the cubital fossa, they'll present very early on, and that's the very common problem. Cubitus varus or valgus, as the case may be, like lateral Monteggias will present with a cubitus varus, and that's a cosmetic deformity which can be tackled later on if the patient feels like. I mean, if the radial head is out of shape.
Dr. Gupta, sir.
Yes, sir.
If we don't repair the annular ligament, what will be the consequences?
Most of these patients will be stable enough. You don't require an annular ligament reconstruction.
Oh.
If it is still unstable after your ulnar osteotomy and fixation, if the radial head is still unstable, then you consider an annular ligament reconstruction in those cases.
In an unstable head, can we pin it for some time? And
Yes, if it is unstable despite your annular ligament reconstruction, you do a pinning from ulna to radius. Use a thick pin. I would avoid a transcapitalar pin because lot of times in my center, the child will come, they'll keep on moving the elbow little like this, and the pin tends to break in the elbow region. And then you are in for a lot of trouble.
My question to Dr. Nirmal. Sir, when there is a malleable fracture in forearms with intraosseous membrane contracture, restriction of movement, how to manage that one?
Is it like a old fracture, malunate?
A malunited fracture with for restriction of movements and clearly shows some intraosseous membrane, narrowing. Then we have to open or just what to do?
So if it's a old fracture with a malunion and clearly you are able to make out that there is a mal reduction actually, and as you are saying there may be a rotational malunion, then those things are not going to remodel. So if there is a significant restriction of pronation and supination that is restricting the day-to-day activities, then you have to go for an osteotomy and reduce it so that you are able to gain the rotatory movements. But again, it's a tricky thing. Like if you have an intraosseous membrane contracture, as you're saying, it's a very chronic case. Then we have to be like we have to keep our fingers crossed how much you are able to get back. But still, we don't expect it to remodel by itself a rotatory malunion. You have to go in and do it. Yeah.
Along with osteotomy, we had to release intraosseous membrane wide release. Anything that might be helpful?
It depends intraoperatively what you're able to achieve. So what we do is we do a rotatory reduction and assess the pronation supination. So it's like you don't expect a complete regaining of pronation supination in these cases, because the more you're going to invade, the more scarring is going to happen. So whatever the functional range we are able to achieve, we settle with that.
So we just need to do like a derotation osteotomy for the radial synostosis like that. Fixed in functional position.
Yeah, we need to have a functional position. Actually, if the child is going to have a limb that is having only fixed in pronation and it's not going to be supination, at least we need to get the limb back to a neutral position or a mid-prone position, so that there is a compensation on both the sides to get day-to-day activities.
Thank you.
Oh, can I add something?
Yeah, please, sir.
Yeah, it's actually, if you see the forearm fractures, it's the ulna which causes a lot of cosmetic issue, and it's the radius which causes a lot of loss of pronation supination. So it depends on the demand of the patient. If it is cosmetic plus loss of pronation supination, you do osteotomy of both. Otherwise, you do a la carte approach. I mean, depending on the demands of the patient. Am I
Yeah, exactly. Yes, sir. Yes.
That's
Dr. Dhiren, sir.
Yeah, please.
Hello. Sir, any tips to pass K-wires in marginal fractures of distal radius in the diphyseal metaphyseal junction? It's very difficult to pass K-wire there. So any tips to pass K-wire there?
Exactly. So that's where I have also faced a lot of difficulty. And that's why I try to suggest that if we pass a one pin from the radial styloid, it's easy. But otherwise, what you said is really a difficult one. I use a guide so that at least we can maneuver the direction of K-wire. But I fully agree with you that it's difficult. That area itself, the curvature of the bone is so much that it's difficult. anyone, any faculty, if they have a suggestion for this difficult situation, I would be happy to learn from you.
But Dhiren, I have tried once or twice passing K-wire at the junction of diaphysis, metaphysis. It's very difficult to get an oblique wire in.
Even
I
after
have
open
tried once passing wire from the top.
Yeah.
The X-ray looks horrible. The wire looks horrible. But I think I read one paper from, it's a Chinese Journal of Traumatology where they have used this technique. I don't have too much of experience. I mean, I might have used in 1 or 2 cases. The fracture united well. The initial X-ray looks, the K-wire looks very horrible. It looks like a very shoddy job done by a surgeon because you're starting from the middle, you're not starting from the end. But eventually the results are, fracture remains stable. So
Can I
Can
add
we use tenseness? We can pass tenseness from antegrade from top to bottom.
it's a little difficult if you pass it. There are a lot of vital structure in the proximal radius. So you try to enter in from the proximal radius, the head and neck junction, you're in for a lot of trouble because unless you have to open very wide.
We need to.
So tense nail is best passed from below.
From
But
top.
the problem is
from top because
the junction
very
between
difficult
the
to pass for
diaphysis.
this fragment.
Yeah, it is a difficult scenario.
From distal because for the both bones for a couple of instances we used to do that. We open proximally and carefully separate the muscle and then we pass from antegrade to down. So that we can have
that's
some
what I was saying. I've done it in a couple of cases.
That would be intramedullary wiring.
Yeah,
not
intramedullary wire.
Intramedullary
Yeah,
wire.
it would be intramedullary wire. These are cases where there are junctional cases.
if you're sorry, can I add?
Yeah.
If you are using an intrafocal pin to reduce the fracture, you can retain the intrafocal pin. You can take a purchase in the other cortex of the distal fragment and you can retain it for some time. You add a splintage to it.
Yeah.
Right.
Yeah, but Nirmal Raj, the intrafocal pin is in the fracture side. So,
Yes,
like
so
keeping it.
Yeah, you have to keep it short. You don't go through the don't pass through the other cortex actually. You stay shy away from the other cortex. You reduce it, and then you can pass it through the other cortex of the distal fragment actually. By that
Okay, so you are talking something like Kapanji buttress.
Yeah, Kapanji, yeah, something like that. Yeah.
Yeah, I have always found difficulty at the junction of diaphysis and metaphysis.
Yeah, that's a difficult area.
That's a difficult area. That's what I'm talking about.
Yeah.
So I've done one time, I just bent the K-wire a little and I entered through the metaphysis and just kind of passed it intramedullary and just punctured the cortex on the other side. So it's like a C-shaped wire and it kind of gives a 3-point corrective force on the fracture. So for the ones which are dorsally angular.
Kapil, how did you pass the wire? Using a chuck or using a
T-handle?
You can't pass
small T-handle. Yeah.
Small T-handle.
But then you can't rotate because the wire which is curved, when you rotate, it makes a big swing.
Yeah, you don't have to like rotate like that. You just kind of do small, wiggle movements.
Yeah, wiggle movement,
till it goes into the cortex. Yeah. The child's bone is so soft, it just punctures it very easily.
Okay, Dr. Chetan, is there any other questions from the panelists?
I don't think so, sir.
So should we wind up here?
I think we should wind.
Yeah, Dr. Puneet is here. Dr. Puneet Gupta, sir. I think you should go for vote of thanks.
So, he is here, but I don't know whether he's listening or not.
I don't think he is here. So you can proceed for vote of thanks.
No, he is here.
He's here?
Yes, but he has muted himself. So you can call him if it is possible. Otherwise,
you can proceed. Chetan?
Okay, I can proceed. Sirohi sir, you wanted to say something?
Yes, I want to thank all the speakers. I have learned many new things. And especially I want to thank Dr. Dhiren, Dr. P.N Gupta and all the others also. But the way Dr. Dhiren explained by cases, many things have been cleared for long time. Thank you,
you,
Dr.
sir.
Dhiren.
Thank you.
Patient, can I make a comment?
Yes, sir.
Yes, sure.
Even in practice, and it's very well that we know how much remodeling is there. When we are dealing with not only the child, we are treating child as well as the parents. With this small, they become very anxious. They will remodel. They want action from stay. So we go and them. So we know that this will remodel, particularly, but we indirectly side to.
Sir, your voice is not very clear. It's breaking.
Vimal sir, your voice is not clear.
Internet connection is weak there.
Maybe. Then we will have. Can you hear me a little bit?
Yes, sir.
What I was saying was, while treating children, we are treating the children as well as their parents, and they become anxious. So we know that 30-degree angulation will remodel. But we tend to, in private practice at least, we try to get the reduction nearly 100% on day one. And in that case, we have to give them GA and sometimes pin it, though we know that this may do without it.
Yeah, yes, that's a dilemma. So sometimes this happens that when they come for in the first follow-up, the reduction is all gone, and then everybody is so fretful, and you have to explain to them really hard.
It is difficult.
Yeah, that's a real practical situation, and if you are the treating surgeon, then it's a real big problem, because then on the first day you have shown that it's 100% reduction, you have boasted about your reduction, and then on the next week now you are trying to defend the displacement. So that's really a difficult situation for everyone.
So
Now what to do, sir? How to explain to the attendants?
So that will be a very difficult topic, and we can have one session on that also.
I think Chetan, we should wind up now.
yes, so I want.
I would request everyone. We are having a session on pediatric trauma in the trauma conclave, and I request all of you to join trauma conclave at Jim Corbett on 7th and 8th October.
Okay, sir. So now I want to thank all the faculty and Dr. P.N Gupta sir, and Dr. Dhiren Ganjwala, Dr. Kapil Gangwal, and Dr. Nirmal for joining and give this pediatric trauma update of Uttaranchal Orthopedic Association and making this really nice program. So I also want to thank Puneet Agrawal sir and Puneet Gupta sir to provide us this platform where we could discuss so many interviewing questions that we as traumatologists face in our daily practice. So over to you, Dr. Puneet.
Yeah, thank you all of you. Thanks all our faculty members. Thank you all panelists. Thank you delegates, and thank you Poonam and Ortho TV team. Thanks to all to join us. Thank you. Have a good night.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.
Bye.
Good night.